Collect the following items: multifunction gastric catheter kit, lubricating jelly, and tape to secure the catheter. The catheter kit includes the catheter, stylet, 10 milliliter syringe, pressure line, and 3-way stopcock. Inflate the balloon with 6 milliliters of air and inspect for damage or defects. Then deflate completely and resecure the cap. Before inserting the catheter, discuss with the team if there is already a gastric catheter in place that should be removed before inserting the new catheter. Removing it after can cause the EBM catheter to be dislodged. Position the patient's head of bed at least 30 degrees elevated. Higher is better if tolerated. Estimate the required insertion depth by positioning the balloon above the xiphoid process. Then extend to the earlobe and toward the corner of the mouth, or nostril if inserting nasally. Note the depth marking, which measures to the bottom of the balloon, not the catheter tip. Note: manufacturer instructions state that the correct position of the balloon is always between 35 and 45 centimeters. Apply a generous amount of lubricating jelly to the end of the catheter. Grasp the catheter with its distal end pointing downward and insert it into the patient's mouth, advancing it into the esophagus. The patient should be monitored for cues that might indicate the catheter has entered the respiratory tract. If resistance is encountered, rotate the catheter slightly and never force the catheter. If catheter coils, or you are unable to advance it, you can try using a tongue depressor or having an assistant perform a jaw thrust. If difficulty persists, then you may attempt to use the stylet. Remove the stylet from its sheath and apply a generous amount of lubricant to the entire stylet. Never insert the stylet when the catheter is in a patient. Insert through the purple gastric port until the stylet reaches the end of the catheter. Note: the catheter may need to be straightened to progress the stylet. Lock the stylet in place and reattempt catheter insertion. Leave the stylet in place until balloon placement is confirmed. Once the catheter has been advanced to the measured depth, secure it to the endotracheal tube by wrapping the tape around the catheter first, then around both the catheter and the endotracheal tube. Fold the end of the tape before securing for easier removal later. Chest X-ray, pressure waveforms, and an occlusion test should all be used to determine the optimal position of the balloon. On chest X-ray, the balloon should be positioned in the lower third of the esophagus, behind the heart. The center of the balloon is identified by a square radiopaque marker. The balloon extends 5 centimeters above and below the marker. Therefore, the marker should be positioned at least 5 centimeters above the diaphragm. In this example, the balloon could be advanced further. If the quality of the X-ray is acceptable and you are unable to visualize the marker, that could indicate it is within the stomach. Another way to estimate optimal balloon depth is by measuring from the tip of the endotracheal tube to the top of the diaphragm. Then add that distance to the endotracheal tube depth. Remove one of the blank cartridges from the front of the ventilator by pushing the dark gray button and pulling on the white lever. Then insert the EBM module. Ensure all ports on the 3-way stopcock are open. Then remove the cap from the EBM catheter's green pressure line, but do not discard it. Connect the stopcock to the catheter. Then connect the pressure line to PUX port on the EBM module. While the stopcock is open to atmosphere, allow at least 1 to 2 breaths and confirm the esophageal pressure waveform on the ventilator is flat and measuring 0. Withdraw 6 milliliters of air into the syringe and connect to the 3-way stopcock. Insert 6 milliliters of air into the balloon, then withdraw 2 milliliters, leaving a total of 4 milliliters in the balloon. Turn the stopcock tap 180 degrees so it is close to the syringe, but open to the ventilator and catheter. Remove the syringe and replace the cap. Verify that cardiac oscillations are present on the esophageal pressure waveform. If not, then apply pressure to patient's abdomen while observing the ventilator waveform. If a positive deflection is noted, then the balloon is likely within the stomach and should be withdrawn until strong cardiac oscillations are observed. Once present, proceed with the occlusion test. To perform the occlusion test on the ventilator, select Maneuvers, then PS Catheter Positioning. When ready, select Start and wait for the beep to sound. Then perform 1 to 2 slow but firm compressions on the mid to left side of chest within 10 seconds. You should observe a positive deflection on the ventilator waveform. If the maneuver was successful, the ventilator will display a green light. Acceptable ratio is 0.8 to 1.2. If not, repeat the maneuver while compressing a different spot on the chest and confirm position of catheter on X-ray. If it continues to fail, observe the displayed end-expiratory transpulmonary pressure. If it is significantly below 0, then increase PEEP until end-expiratory pressure is closer to 0. Allow it to stabilize, then repeat the maneuver. Significant airway collapse can prevent proper measurement of end-expiratory alveolar pressure. If it continues to fail, or cardiac oscillations are not strong, a stepwise balloon filling optimization may be required. Transpulmonary pressure is calculated as the difference between pressure inside of the lungs and pressure outside of the lungs. At end exhalation, it indicates whether lungs are remaining inflated or collapsing. And at end inhalation, it represents true lung stretch. This helps guide adequate and safe ventilator pressure levels in cases of reduced chest wall compliance. Optimize PEEP using the end-expiratory transpulmonary pressure. An expiratory hold is required for accurate measurement. Maintain the hold until the ventilator pressure waveform has stabilized and observe the PLei value. Ideal PLei is a positive value of 0 to 2 centimeters of water. However, 0 to 5 centimeters of water is acceptable. If PLei is too low, increase PEEP. If it is too high, then decrease PEEP. If patient is hemodynamically unstable, a slightly negative PLei may be required. Discuss with M or HB. PEEP level changes should be allowed to stabilize before repeating a breath hold. Repeat until the set PEEP results in the desired PLei. Once PEEP is optimized, the airway driving pressure should be measured and used to titrate tidal volume. Perform an inspiratory hold to measure both the end-inspiratory transpulmonary pressure and the driving pressures. Note, the correct values for these are the ones that appear immediately after the inspiratory hold button is released. The PLei should be less than 20 centimeters of water, the airway PLdrive should be less than 15 centimeters of water, and PLdrive less than 12 centimeters of water.